We admit we have an informal competition inside UNICEF for the most pretty cover of the annual results report, and I have actually put my vote on ours. You'll see this healthy bouncing baby from Uganda on the cover of our report, and I think you'll agree with me. Even Chewa.
I think this fits that.
Wonderful. So, anyhow, I'm very happy to talk to you about where we've been in 2016 and how we intend to move forward in the coming year. As you've seen, that the MDG era was an era of unprecedented progress in terms of reducing under 5 mortality. We more than halved the under 5 mortality from 1990 to 2015, from 12.7 to 5.9. And that actually it also conceals a considerable acceleration we did after the year 2000, where we more than doubled the reduction rate in under 5 mortality, actually saving the lives of another 48 million children as a result of that. Now, as we move forward, we see that it's more a question of inequities between countries and within countries. And 80% of this under 5 mortality is now concentrated in Africa and South Asia. And that's obviously where we have a lot of work to actually finish this. What kills children is not rocket science, and fixing it is not rocket science. There are 4 causes of childhood deaths that we need to remember. It's delivery and the first month of life. It's pneumonia, diarrhea, and malaria, in that order. So delivery, pneumonia, diarrhea, mortality. And we know what to do. We can even afford to do it as a world, but it has yet to happen. And that's the challenge, actually, to fix that. Then, as we add to this, we see that as we reduce the relatively older child mortality, newborn mortality and mortality in the first 28 days becomes much more important. Globally, we now count 45% of under 5 mortality in the first 28 days. And that's actually cheating, because then we haven't even counted 2.6 million stillbirths, which we need to start counting. At least half of those are amenable to the same solutions that will save newborn lives when they come out. So, as we're now targeting under the SDGs an under 5 mortality rate of 25 the world over, we have 47 countries who are actually off track with the current rate of reduction. We have 30 countries that need to at least double the rate of reduction, and we have 11 countries that need to triple their rate of reduction. So, good enough, it's relatively fewer countries, but there is a huge effort to be done to actually complete the unfinished agenda, if you will, of the Millennium Development Goal era. Now, we have a context that we're working on, and a few distinguishing features I'd like to point out to you is that we have more emergencies, we have more protracted crises, we have new epidemics, etc. occurring. We're also starting to see climate change effects in terms of drought, even in terms of migration. We see also that much as pneumonia, diarrhea, and malaria remain the chief causes of mortality, increasingly we've succeeded in convincing women to come and deliver in health facilities, but the numbers aren't there because the quality of the delivery care is insufficient. So as we move from MDGs with a focus on access, in the SDGs it's a focus on quality. It's not enough to come, you also need to get what you deserve when you come. We have also been working with partners in AID, WHO, Gates, etc. to reconceptualize child health in the SDG era. A few headline bullets from some retreats we've had on that is to say that it's a 2-decade thing, it's a life course thing, it's about integration and putting the child back together from a number of vertical disease-specific initiatives. And that it's about national leadership and national capacity to take on this agenda and have that capacity built to be able to drive this. And I think we see a fantastic opportunity also now with the election of Dr. Tedros as head of WHO. The slogan universal health coverage, and making universal health coverage a reality will require strategies that actually reach women, children, and the disadvantaged. And we're in an excellent position to do that. Thereby also tackling health security issues such as epidemic preparedness, antimicrobial resistance, etc., by building community health systems. Now, looking at what we can report from the last year and the strategic plan which we are now closing, we had 3 areas. We had enhanced support for children and caregivers, increasing capacity and strengthening commitment of government to improve health and reduce mortality, evidence, advocacy, and partnership. So that's, as you will see, our beautiful report. I hope you've picked it, it's at the table there. It retains this structure. So, overall, what did we achieve? Well, overall, actually, in 2016, we made a heroic effort to calculate that we have achieved 85% of what we set out to do across those 3 areas. Programmatically, and I'm just giving you a snapshot of a few numbers here. 61 million children immunized against measles, 58 against diphtheria, tetanus, and pertussis. 11 million women protected against tetanus, which we're trying to eliminate. Not eradicate, but eliminate. We've remained the biggest procurer of vaccines in the world. And in fact, 45% of the world's children get immunized with vaccines that have somehow been procured by UNICEF, either directly or on behalf of governments. We've worked with 50 countries on communication plans, pushing forth maternal, newborn, and child health. We've trained almost 75,000 frontline health workers on how to better care for children. And this we're very proud of. We've oral rehydration solution, very low-tech, appropriate solution that I don't need to explain the benefits of you to. We've had 0 stockouts in 126 out of 139 countries. So we worked on supply systems. Continuing the list, we have in this year responded to 344 humanitarian situations in 108 countries, which is a lot. We've vaccinated more, and I'd just like to point out that the epidemic you didn't read about was the yellow fever epidemic in Kinshasa, Democratic Republic of Congo. Because under a global shortage of yellow fever vaccine, we worked very much with partners and government to actually prevent that epidemic. So this is one headline that we spared you, which was imminent at one stage, that yellow fever would actually spread to Kinshasa. We've worked on Zika. We continue working out, pushing out, eradicating polio. In Pakistan alone, we have 17,000 workers that are busy now, house to house, chasing out the last polio. And this year, we're at less than half of last year's rate. So we're very hopeful that we're actually seeing the end of polio. We've worked on health system strengthening guidance, and I'll return to that in a moment. And we're working together with colleagues in other sections here on 2 projects that I briefly want to talk to you about. One is about adolescent mental health. Do you know that suicide is a top cause of death among young girls the world over, on par with all the reproductive mortality, which you need to tackle at the depression stage and not already at the suicide stage? The second piece we're working on with colleagues here in other sections is around finding children with disability early enough that you can still rehabilitate them and save a lot of function. So how do you find the approximately 10% of children with disability in the first year or 2, and what can you do there? So those are exciting projects we're doing together. Now, we also work with partners. Obviously we are implementing the Every Woman, Every Child partnership led by the Secretary General, but in particular I'd like to point out Lu Wei. Would you stand for recognition? Lu Wei Pearson, here, my deputy, she chaired, or actually you carried out UNICEF's chairpersonship of the H6, the UN Health Agency collaboration during the year, where we actually led the other agencies and identified national leads across the focus countries. So, and you see the long list here of other agencies, and many are missing. UNITAID, and of late I'm now very much involved in the interagency coordination group on antimicrobial resistance, which may be on some of your top agendas. Now, the year has not been without challenges. Health workers have become targets. Health facilities are targets in humanitarian settings, as you know. Previously they were protected, now they are deliberate targets. This is, coupled with repeated emergencies, is a big challenge in the humanitarian setting. We also see that governments are actually still weak to take up the required coordination and technical lead that is required in the SDG era, so we're working on that. We still have challenges on data, using data. We have taken great strides together with many of you support in this room to actually display data for scenario building and decision making in a software application called Equist, that we can tell you more about. And we've had, believe it or not, shortfalls of money. We have not done as much as we wanted to, particularly tackling integrated manner pneumonia, diarrhea, malaria through integrated community case management. We have not done as much as we'd like to in chasing tetanus, neonatal tetanus out. We've been unable to afford to buy the Uniject tetanus needles that you can use in humanitarian or difficult settings. And we've had limits to what we can do in our approach to health system strengthening, going from vertical to integrated. So obviously this will lead to a plea, as you can see in the later slides. This is how monies have gone over the last 3 years, and I'd like to draw your attention to 2 trends here. One is that what our liquid gold, the regular resources that so many of you provide, have actually as a proportion been going down. These are the untied money that we can use to develop new projects and do other things, including the adolescent mental health and other things. Meanwhile, the earmarked resources have been going up. So those are trends that go in opposite directions that worry us a bit, that we'd like to discuss with you. The biggest recipient of our country for health remains Democratic Republic of Congo, where we're doing a lot of system strengthening in, as you know, a situation of persistent weakness and fragility. Looking at our resources, immunization continues to be a big thing for us, obviously, and it's the bedrock of what we're trying to build in community health systems. Polio is expensive to eradicate polio for the world. So in fact, over this last year, you've seen more resources going into this. Meanwhile, down here, maternal, newborn, and child health, we actually see a worrying trend of less money being spent on maternal, newborn health in last year, in spite of the increased significance under the SDG era. We're also seeing that child health is increasingly becoming orphaned as donors and international interest is shifting to other areas. Health system strengthening will be very important to actually bring out the integrated care aspects, going from the era of tackling diseases to actually universal health coverage, helping patients in an integrated manner. Here we'd like to be able to do much more to bring about universal health coverage through community health systems. Now, this health and emergencies has concentrated to a large extent in the Middle East. Syria, Yemen, and those messes have really concentrated a lot of our emergency spending and activity and continue to do so. To some extent, actually sucking money from Africa. Then I have good news for you as well. We've become more efficient. Over the strategic planning period, we are now spending 14% less on general issues. We're spending 8% less on travel, and we're only spending 1% more on staff. So aren't we doing good? Okay, here's my pitch. Global thematic funding is really liquid gold for us. Much as we are the biggest section in UNICEF, 1.4 billion expenditure in 2016, in a decentralized organization, a lot of it raised and spent at country level. What I alluded to, the earmarked funds and the decrease in flexible funding is worrying to us. We have received 13 million in thematic contributions, with Sweden being #1. But actually, the majority of that, all except a few percent of this, is actually spent at country level in few targeted countries, Zimbabwe, DRC being the top ones. While as for me and Lu Wei here running a health section here, we have $2 million in thematic funding to actually develop new things. Take on the adolescent mental health, develop more adolescent programming, work on disability in the early period, take on antimicrobial resistance aspects from UNICEF, operationalize universal health coverage, etc. So it's a plea to you to increase this. This is what is my liquid gold that can allow us actually to develop new agendas. Now, quickly, health system strengthening. It's a funny word. What does it mean? What do we do? Well, actually, we're operationalizing it at one level through a community health platform and at another level through quality primary health care. And this is actually, I'm happy to pass around here actually the documents, our strategy and synopsis of the health system strengthening agenda. We envision a cadre of paid frontline health workers, community health workers, private sector, nurses in dispensaries, etc., who can do preventive, promotive, and curative work multi-sectorally, and who have essential commodities. Essentially, the Ethiopian model, if you will. Secondly, once you reach the health center, and here you're received by a midwife, that midwife needs to be able to wash her hands to begin with for quality of care to result. She needs to have the tools and implements and ideally the electricity to conduct deliveries. So we have a focus here on quality improvement at primary health care and moving from access to quality. Underlying this, still national planning and investment. We're talking about scenario building, investment cases, and what have you not. Supporting the district level where a lot of, in decentralized systems, things get implemented or not. Working together with Norway, DHIS2, University of Oslo on operationalizing DHIS2 in a number of countries, and obviously strengthening national procurement, supply and management systems to make sure that monies are there. So, where are we moving now? We are actually moving towards more of the same. In the sense that we still have an unfinished mortality agenda to do. An unfinished mortality agenda which is focused to a large extent in Africa and to some extent in South Asia. And we're not letting go of that. And we have two strategies. The one is the community health system, and the other one is the quality of care in health facilities. We see immunization as a key strategy within this, that we can actually also build other multi-sectoral action on. The Health Emergency Preparedness Initiative, the Zika, the dengue, the chikungunya, disease outbreaks. These are sort of the fire brigade things we have to do all along. And there's a lot of fire brigade issues, I must say. We're working on the global health leadership. A tremendous opportunity now is to operationalize universal health coverage for women, children, and the disadvantaged. I think we have a golden moment between our friend Dr. Tedros and ourselves to make this happen across this world now, together with you. And then building the evidence base and the programming for adolescents as we've taken on in the plan, the second decade of life. I'd like to appeal to you also that the thematic health will really help us, not the least to support with technical assistance the global initiatives where the money is increasingly sitting, that value our input both at the global and country level, but that with the exception of Gavi don't pay us for us. So we need to be enabled to actually give you value for money, be it through UNICEF or through global initiatives. So the acknowledgements are due to several of you around this table here, be you bilateral donors or NatComs. And with that, I'd like to hand over, Madam Chair.